Module 10, Ethical Issues in Geriatrics. Caring for older adults, particularly those with cognitive impairment, complex multimorbidity, and disability, presents myriad ethical challenges around autonomy, capacity, safety, and dignity. Balancing beneficence and non-maleficence principles while respecting unique circumstances and patient preferences underscores complex decision-making regarding management options and transitions toward end-of-life care. This module outlines key ethical considerations and frameworks guiding best practice. Decision-making capacity. Assessing capacity focuses determining ability to comprehend and manipulate knowledge toward reasoned decisions, appreciating consequences. This fluid construct relies on 4 pillars outlining understanding, appreciation, reasoning, and evidencing a choice. Documenting capacity fluctuations through observation aids determining optimal timing for consent processes. Structured approaches clarify reasoning and values directing choices. However, patient preferences still carry weight amid impaired decisional capacity given prior coherent health priorities. Judgment relies on context, including urgency, irreversibility, and risk balancing. Multidisciplinary input ethically optimizes outcome determinations, although ultimately courts determine contestable capacity dilemmas. Elder abuse and vulnerability. Marked power differential conferred by hierarchy, reliance, or trust predisposes abuse encompassing emotional, physical, sexual maltreatment, or financial exploitation. Ageism compounds vulnerability. Dependency relating mental impairment or disability escalates risk further still. Careful history elucidation aided by screening tools identifies suspicious patterns. Mandated reporting legislates responses, particularly if lacking capacity. Interventions prioritize safety and counseling alongside addressing reversible drivers relating mental health or addiction. Maintaining autonomy remains a challenge, often requiring monitoring or segregated finance management. Understanding systemic disadvantages and social determinants empowers responding effectively while upholding dignity. End-of-life care challenges. Frailty inevitably culminates in futility, where death enters imminently into view. Emotive considerations around tube feeding withdrawal or ceasing dialysis may arise, demanding cautious communication, conveying prognosis to patients and families as options narrow. Equally complex are stalled conversations determining appropriate resuscitative boundaries. Conceptualizing terminal transitions ethically involves acknowledging dying as part of living. This paradigm values quality and meaning rather than solely quantity of survival. Therefore, care appropriately sustains personhood rather than unnecessarily prolonging distress in the process of dying. Such insight facilitates dignified closure through hospice input addressing emotional and symptomatic needs at life's completion. Case example 1. Assessing capacity in dementia. John, 82 years old, carries a dementia diagnosis with dysphagia and hemiparesis following an old stroke. His confusion fluctuates amid 4 hospital admissions over 6 months for pneumonia aspiration. John's daughters dispute whether he possesses capacity for discharge care decisions as he inconsistently recognizes them. Formal capacity screening confirms intact understanding and appreciation of worsening condition and escalating care needs. John evidences clear values, preferring home time rather than institutionalization. His expressions of choice remain rational, although communication barriers exist. Capacity determinations enable patient-centered discharge planning respecting autonomy. Case example 2. Identifying and managing elder abuse. Mary, age 79, called emergency services repeatedly for minor ailments, but injuries, including bruises and scalds. Her daughter Amy, age 55, moved in recently following divorce and accompanies all medical reviews, limiting Mary's ability to speak openly. Mary appears withdrawn, underweight, with poor grooming and dental hygiene. She demonstrates fearfulness, insisting nothing is wrong. Recognizing coercive, controlling abuse patterns facilitates sensitive interviewing, assessing safety when separated. Referral to social and legal supports ultimately enables Mary choosing respite housing despite Amy's protests, upholding well-being and rights. Counseling aims to rebuild family dynamics longer term. Empowerment models restore confidence after abusive power imbalances, while monitoring attempts gradual reconciliation. Conclusion. This module has outlined key concepts and practical approaches navigating common ethical dilemmas affecting vulnerable older adults. Determining capacity fluctuations, identifying undue coercion, and respecting evolving priorities are critical skills for geriatric practitioners seeking to align management with patient values during transitional phases toward life's completion. Sensitive communication and ethical frameworks guide this difficult